Good afternoon. Thank you. Welcome to the 2026 Kreuter Katz Lecture. I hope you've really enjoyed the lightning sessions, panel presentations, and student poster sessions, as well as each other's company today. Today's symposium is named to honor two of our school's most dedicated supporters, Marshall Kreuter and Martha Katz. Marshall was one of the earliest faculty members in what was then known as the Institute of Public Health at Georgia State. During his exemplary career here, he led several community-based participatory research projects focused on health equity. Prior to joining Georgia State, he was a distinguished scientist at the Centers for Disease Control and Prevention. His leadership roles at CDC included Director of the Division of Health Education, inaugural Director of the Division of Chronic Disease Control and Community Intervention, and Director of the Prevention Research Center's program. Martha also had a distinguished career at the CDC, where she served for 22 years as Deputy Director for Policy and Legislation. In this role, she advised the CDC Director on policy issues and provided leadership for the agency's legislative initiatives, health communications programs, and relationships with external partners. She previously served as Director of Health Policy for Healthcare Georgia Foundation and was instrumental in the establishment of the CDC Foundation. Both Martha and Marshall exemplify the importance of building research partnerships and translating findings into evidence-based practices and policies that change lives forever. I'm very pleased that Martha could be with us today. Martha, could you wave so everyone can see you? The Kreuter Katz Lecture Series was launched more than a decade ago with initial funding from Healthcare Georgia Foundation, which is known as today as the Georgia Health Initiative. The inaugural president of the foundation is here with us. Gary Nelson, could you wave wherever you are? Please acknowledge Dr. Nelson. Generous support from additional donors has enabled us to endow the Kreuter Katz Lecture and then expand it to a full-day research symposium that will honor Martha and Marshall's legacy in perpetuity. Now it's my pleasure to invite Dr. April Ballard to the stage. Dr. Ballard is an assistant professor in the Department of Population Health Sciences and co-leads our school's Center on Health and Homelessness. Please join me in welcoming Dr. Ballard.
Good afternoon, everyone. Thank you all for being here. It is my great pleasure to introduce our Kreuter Katz keynote speaker today for this year's School of Public Health Research Day, as we focus on health and homelessness and the critical role of research, policy, and practice in addressing this issue. Dr. Margot Kushel is a professor of medicine at University of California, San Francisco, Division Chief of the Division of Health and Society, and Director of UCSF Action Research Center for Health and Benioff Homelessness and Housing Initiative. She's also a practicing general internist at Zuckerberg San Francisco General Hospital. As a physician, researcher, and leader, Dr. Kushel has made nationally and internationally influential contributions to our understanding of the complex and deeply intertwined relationships between housing instability and health. Her research is grounded in a clear and urgent goal: reducing the burden of homelessness on health. Her work examines strategies to prevent and end homelessness while also addressing the profound health consequences of experiencing homelessness. Using a wide range of research methods, she focuses on translating evidence into actionable programs and policies, working closely with communities, policymakers, and health systems to create change. In addition to her research, she is deeply committed to mentorship, clinical care, and public engagement, maintaining an active primary care practice, mentoring the next generation of investigators, and regularly provides expert testimony and guidance at the local, state, and national levels. We're honored to welcome you to GSU to share your insights into today's keynote, Homelessness, Causes, Consequences, and Solutions. Her work speaks directly to the mission of our Center on Health and Homelessness, and so please join me in welcoming her today.
Thank you so much for having me. I'm sorry, I seem to have brought a cold from the West Coast, and so I'm sorry if my voice is a little hoarse here. It has been a true honor, and I'm really honored to be here, really honoring the incredible legacy of Drs. Kreuter and Katz. I'm going to talk about homelessness causes, consequences, and solutions, and hopefully engage in a conversation. I have been so inspired by your center, which is new and already making enormous impact doing community-engaged research. So 771,480, to me, sort of sounds like the lyrics to a bad Broadway musical. But it's actually the estimated number of Americans who experienced homelessness on one night in 2024. Side note, that is the last data we have, longer, not so long story. We know it is a vast underestimate. As your research and others have shown, many people do not get counted in this, and also it's a point in time. It's at one moment in time, not the story of everyone who has this experience over the course of the year. In Georgia, 12,290 Georgians are estimated to experience homelessness on any given night. So I always want to start with a framing because this is a conversation that is incredibly politically charged. I often have hate mail sent to me because people have all sorts of feelings about this. In this terrific book, In the Midst of Plenty by Mary Beth Shin, crazy coincidence, she's my mother-in-law, and also really odd, and Jill Kaduri, a terrific book sort of walking through the academic research on homelessness. They make a really important point, and that is when people ask, why are people experiencing homelessness, they're actually asking two different questions. They're often asking, why are there so many people in a region who experience homelessness? Why, when you come to San Francisco, are so many people experiencing homelessness? And the answers to that are really almost entirely structural. As I'll talk about, it's really the mismatch between the availability and affordability of housing and the number of extremely low-income people. But they're also asking a different question, which is, why is this particular person experiencing homelessness? Why is Mr. Smith experiencing homelessness? And the answers to that often point to individual vulnerabilities, which increase a person's risk. The problem that we have in our body politic is we're often asking the first question, but answering it with an answer better suited to the second. Now, when I think about homelessness, I often find myself relying on a rubric or a thought process put out in the early 2000s in this oldie but goodie, Helping America's Homeless by Lawton Aaron and Marty Burt, where they talk about the phenomenon of homelessness as an interaction between structural factors, affordable housing, stagnated wages, income inequality, et cetera, racism, and individual vulnerabilities, so the rate of substance use disorders, mental health disabilities, adverse childhood experiences, and the presence or the absence of a safety net, what catches you when you're going through a hard time. And they note that the less favorable the structural factors and the safety net is, the fewer individual vulnerabilities you need to become homeless. So if you ever get to travel, let's say, to Northern Europe, very flat income structure, a lot of social housing, very strong social safety net, you will still see people experiencing homelessness, but they will be people who have very severe individual vulnerabilities. In Atlanta in 2026, in San Francisco in 2026, obviously if you have those vulnerabilities, you're at extremely high risk, but you don't need that many vulnerabilities to become homeless. I take care in my clinic of many Uber drivers working 18 hours a day and sleeping the other 6 in their car. I take care of many janitors, many workers who have never experienced an individual vulnerability, but are out on the streets or in their cars. Now, finally, this is from a book by Clayton Aldern and Greg Colburn. Fantastic book. You can read it in an afternoon, Homelessness as a Housing Problem. I also love any book that if you don't have the afternoon, you can kind of get the gist just reading the title. But in that book, they distinguish the drivers. These are the systemic factors that create overall homelessness rates and the difference in homeless rates between communities from the individual vulnerability. And they point out using data that you can draw a really beautiful regression line between the lack of affordable housing and the extremely low income people in a community and the rates of homelessness. And it is a scatter plot, no relationship between the rates of substance use and mental health disabilities. So if you look at who has the highest rates of substance use or mental health problems, you often get to Appalachia or the former Rust Belt, which have extraordinarily high rates of despair, of mental health problems, of substance use, and some of the lowest rates of homelessness. If you go to a state like California, which is actually mid to low on the substance use and mental health disabilities, we are way up near the top of rates of homelessness. Now, when they called me about this book, I use this analogy. Greg later told me everyone uses this analogy, and I think they wrote it up better, so I'm going to use that. If you're trying to explain this at a dinner party, I love this analogy. They use the analogy of musical chairs. So if anyone's ever been to a kid's birthday party in the game, you've got 10 chairs, you've got 10 kids, the adult plays the music, the kids walk around, the adult pulls away a chair and turns off the music, and the kids scramble for the remaining chairs. Now you can do a thought experiment. You're a bunch of parents, you're kind of bored, you're having your rosé while you're watching the kids play this game, and little Timmy comes in, and he sprained his ankle the day before, and he's on crutches that don't really fit, he doesn't know how to use them. So if you're a parent sitting there taking bets on who's going to be standing, it would be a pretty good bet that Timmy's going to be the one standing, because he's going to have less ability to dive for the 9 remaining chairs. So if you ask the question, why is Timmy standing? Well, Timmy's standing because he sprained his ankle and he can't get to the chair. But if you ask a different question, why is there a kid standing? Well, you have 9 chairs and 10 kids, and either 2 kids are sitting on top of each other or somebody's going to be standing. And I would further extend that metaphor. What if you hadn't taken away a chair? It might have taken Timmy a little longer, but eventually he too would have sat down. The reason we have so much homelessness is not that we have so many people who sprain their ankle or so many people with individual vulnerabilities. The reason we have so much homelessness is we simply don't have enough chairs or housing. So how many chairs do we have? So I am a nerd, and every March I look out for the new GAP report from the National Low-Income Housing Coalition, where they go through the country and major metropolitan areas and look at this disconnect between housing and incomes. And what they really are looking at is the number of units that are available and affordable. Available means they exist, they're not occupied by higher income household, they are habitable, and affordable, meaning that a person can afford it, a household can afford it, spending less than 30% of their income. And because homelessness is concentrated on extremely low income, they look at it for extremely low income households. So those are households that make less than 30% of the area median income. Now, San Francisco has a different area median income than Macon, Georgia has, but every area has an area median income. The fact that those two numbers are 30% is just a bad coincidence, but basically the idea is if you're very poor, you can't spend more than 30% of your income on housing, because if you do, you have no money put aside for a rainy day, you're not spending it on healthcare and the like. In our country right now, we have 35 units of housing that are available and affordable for every 100 extremely low-income households. We are over 7 million units short of where we need to be. Now, if you look on this map and look at the red states, if I had some gripe with them, I said, why did they choose red? It doesn't really match with how we think of red and blue. But if you look at the states in red here, they are the states with fewer than 30 units per 100 households. They are also, with the exception of Hawaii and New York, which I'm happy to talk about why they're exceptions, are the states with the highest prevalence of homelessness, 1-to-1 ratio. Now, my state, California, is up to 25 per 100. We're actually celebrating this because a few years ago we were at 21. We are actually really trying to fix this problem, but it's going slowly. Georgia, you can look at, you can say, oh, you're a little better than the rest of the country. You're at 37 per 100. It's terrible, but it's better than the rest of the country. But it's not that people are equally free to move throughout the state, right? People are where their families are, where their churches, where their jobs are, et cetera. And if you look in the Atlanta metro area, you're at a dismal 27 units per 100 extremely low-income households. Why do you have so much homelessness in Atlanta? That's why you have so much homelessness in Atlanta. Now, finally, before I dive into the actual talk, I feel like as a white woman, I made myself a promise a number of years ago that I would never open my mouth about homelessness without calling out the elephant in the room. And that is, at its heart, homelessness is an issue of racial injustice. And every time I get screamed at, people are yelling about mental health and substance use, but they're never yelling at this much more obvious problem. As a reminder, in our country, and it didn't have to be this way, but this is how it is, the single biggest ways that families build intergenerational wealth has been through home ownership, which exploded in the US in the post-World War II era. Now, until extraordinarily recently in our collective history, it was legal. It was immoral, unethical, and frankly and outwardly racist, but perfectly legal to discriminate on the basis of housing. And this operated in many different ways, but one of the most important ways was through the process of redlining. Basically, homeowners were allowed to write into their title that you could only sell to another white homeowner, and basically communities did this. So they were communities that were all white, and then communities where the people of color lived outside those zones. And then the banks got into the action, and they basically said, if you don't live in one of those all-white communities, we're not going to offer you a mortgage. Or if we do, we're going to offer you a mortgage at terrible rates. This, more than anything, led to the complete loss of home ownership in Black and brown communities, which were basically shut out of the post-World War II boom in housing. It led to racially segregated communities, and it is the single biggest contributor to the intergenerational wealth gap between, let's say, Black and white households. Now, that has been illegal since the fair housing laws passed in the late 1960s. But if you dropped down from Mars and had to guess where those maps were drawn, you could still guess, because we still live in those segregated communities. And you have some communities that have a lot of wealth and a lot of stability, and other communities that have really been disinvested. Now, a reminder, how do we pay for our public schools? By local taxes. How do we, do all of these things? And we still live in those neighborhoods. This, thank goodness, has been illegal since the late 1960s, but it has not left us. Other than the fact that we have these invested and disinvested neighborhoods, we also see things like the predatory lending crisis of 2008, where Black and brown households were targeted for predatory loans, and it led to an enormous loss of wealth, again, in Black and brown households. Even though it is illegal, there is well-documented discrimination in our rental markets. There are these great sort of secret shopper studies where they'll create a fake housing like resume. How many evictions you've had, credit history is, how many kids you have, et cetera. And they will send some white folks with stereotypical white names and the same resume as Black folks in to look for housing. And the white folks are much more likely to be accepted to rent it. So Black folks wind up living in poor quality housing that they pay more for. Now you add to that all the well-documented discrimination in our criminal legal system, in our employment system, and educational discrimination, and perhaps it's not a surprise that Black Americans are at 3 to 4-fold increased risk of homelessness. This is not because Black Americans have higher rates of substance use. They have much lower rates of substance use. It is a legacy of this structural condition that we've created. So why am I a physician talking about this? Well, I like to say there is a loop, and you can start anywhere in the circle, and you can go in any direction, and you'll be right, between physical and behavioral health problems, substance use and mental health problems, homelessness and trauma. People who experience trauma are more likely to have physical and behavioral health problems, with that increased risk of homelessness. People who are homeless experience trauma, and it worsens their physical and behavioral health problems, and so on and so forth. So why am I here as a Californian? Well, this is our number of people estimated to experience homelessness in the state of California on one day in 2024. We have 12% of the nation's population and about 28% of those experiencing homelessness and 50% of those experiencing unsheltered homelessness. In the end of 2019, we were asked by our Department of Health and Human Services, or Health and Human Services Agency, to conduct a representative study of homelessness. We wound up working with 3 incredible community advisory boards, including a very active board of people with lived experience, to design and conduct the largest representative study, mixed method study of homelessness in the US since the 1990s. We published the initial report in June 2023. All of these reports are available on our website. So what did we learn? Who experiences adult homelessness in California? First of all, people experiencing homelessness in California are Californians, people who lose their housing and have no money and not a cent to their name, don't suddenly pack themselves up and move to the state with the highest housing costs in the nation. 90% of people were Californians, lost their housing in California. The other 10% were mainly people who were born in California who lost their housing somewhere else and came to stay with their family. 75% were last housed in their current county. I learned last night, which I'd never realized, is that Atlanta has 2 counties within the city of Atlanta. We have pretty permeable county borders, and yet 3/4 of people were in the same county. People don't move that much. Here's the racism playing out. In our state, 7% of adults identify as Black, but 26% of those experiencing homelessness do. 12% reported a Native American, Alaska Native, or Indigenous identity versus 3% statewide, and we were not on any tribal nation property, and 35% reported a Latine identity. Like most studies of homelessness that are cross-sectional and therefore over-capture people who were homeless for a long time, most were men. 69% were cis men. I will say that 1% were trans or other gender identity. If you go down to the younger folks, that went up to 7%. But speaking of age, this is an aging population. The median age was 47. The oldest person we met was 89. 48% of the single adults, so we, for this, took out the moms with kids and the very young adults, were 50 and older, 41% of whom had never been homeless, not even for one night before the age of 50. In California, if you're homeless, you're going to be unsheltered. When we look at the places slept most in the prior 6 months, 78% were unsheltered. 21% were living in their vehicle, 57% were living in a non-vehicle setting. This is a photo we took during our study, and this is what a lot of California looks like right now. Only 22% had spent most of their nights in homeless shelters. Again, cross-sectional study, we oversample people who are homeless for a long time, but in a way, if you're a policymaker, you care about who's homeless right now. 22 months was the median length of the current episode of homelessness, and 38% met federal criteria for chronic homelessness. So how did people come to be homeless? First of all, 19% of people were home in an institution the night before they became homeless. And these were mostly long stays in jail or federal or state prison. This is an underestimate because in California, most people who exit state prisons get transitional housing for 3 months. They count it as housed, but really their future was set because of their institutional stay. 49% were housed in what we call the non-leaseholder arrangement. This is an arrangement like being doubled up with family or friends. The reason this is important is if you're in that, if you're in an extended stay hotel, if you're doubled up with family or friends, you don't have any legal rights, and things like eviction prevention doesn't help you at that point. You're already post-eviction. 32% came right after being evicted. People were extraordinarily poor. Now, in California, the median cost of a studio apartment statewide is about $1,500, but the median household income in the 6 months prior to homelessness was $960. Non-leaseholders, it was $950. 43% didn't pay rent. But look at the leaseholders. Their median household income was a little higher, $1,400, but they were spending $700 a month on housing. Now, if you were keeping your family afloat on $1,400 a month, you cannot spend $700 on housing. You have no money left for food, for education, for transportation, and the like. But also, if you lose that housing in California, there is no place in our state, rural, urban, no matter where, that you can re-enter the housing market for as little as $700 a month. People had extremely little warning prior to becoming homeless, a median of 5 days. The non-leaseholders, 1 day. They were doubled up, overcrowded conditions, staying with family or friends, things fell apart, and they fell apart quickly, or they were in an extended stay motel and got evicted immediately when they couldn't pay. The leaseholders were a little longer, 10 days, but in California, we have strong rental rights. Most people have 30-day notice warning, but here's the thing, if you fall behind in your rent, you can get a 3-day pay or quit, but also most people got a warning that they were going to become evicted, knew that they had an eviction on their record, they never re-enter the housing market, and just fled. Few people, here are the reasons people lost their housing. You can see on the non-leaseholders, people, it was mainly around conflict or not wanting to impose because people were overcrowded. But if you look in the leaseholders, it was lost or reduced income. Again, we have strong rental protections. It wasn't that people's rent was suddenly being, increased. It was that people lost, hours at the restaurant they were working at, or someone got sick and couldn't contribute. Almost nobody sought or received any help. Only 36% sought any help before they left their place, and that was mostly from friends or family, and only 23% received any help. Now, we put people through a hypothetical sort of thought experiment of what would have prevented their homelessness. And what we found was that 70% of people said, if someone had gotten to me with $300 to $500 a month, I could have never entered homelessness. I was constantly falling $400 behind on my rent. 82% said, you give me $5,000 to $10,000, I would have been able to catch up with my rent or would have had moving expenses, and then I would have been fine. And 90% we basically described a housing choice voucher, and 90% were like, yeah, that would have solved it for me. This was one of our participants. The first thing I did was I cried because I couldn't believe that I was actually homeless for the first time ever. I've always had a job. If I was unemployed, I was never unemployed for more than a month before finding another job. As time progressed, those things became harder. So what was the experience of homelessness like? In a word, it was harrowing. Most of the time, we're running around trying to figure out where we're going to sleep at night. We're not worried about going to the doctors or going to see somebody or going to get help with our mental state. Homelessness, as another participant said to us, was a full-time job. Oops. People's health was incredibly poor. If I could ask people one question that best predicted whether we're going to wind up in the hospital or dying, I would ask them to rate their health. 45% reported their health as fair or poor. The only other population we see this in is people 85 and older. 60% knew they had one or more major chronic disease. This was a vast underestimate because people didn't have much access to health care, but these were things like a cancer diagnosis, congestive heart failure, hypertension. 12% had 3 or more. These were the main diseases people knew about. High blood pressure, 30% knew. 11% knew they had diabetes, even though even in the general population, half of people with diabetes don't know. 25% had chronic lung disease. 7% had a major cancer diagnosis. 34% reported difficulty when at least one activity of daily living, like buttoning their clothes or getting up from a chair. And 16% had difficulties with 3 or more, which usually make you eligible for nursing home care. 22% said they couldn't walk across the room, but people were living in the conditions like you saw and had no access to transportation and had to walk long distances. In their lifetime, 25% had received a diagnosis of post-traumatic stress disorder, and 31% had made an attempt on their life. 27% had been in a psychiatric hospital. 44% had happened after their first episode of homelessness. Symptoms, mental health symptoms were extremely common. We sort of described severe symptoms and had people say if they had them or not, but it was really mostly driven by anxiety and depressive symptoms, which couldn't really blame people if they're living outside and terrified, but 12% reported that they were currently experiencing hallucinations. 37% were using illicit drugs, and for this we asked about methamphetamines, non-prescribed opioids, and cocaine. We're using them at least 3 times a week during this episode. The story in California is all methamphetamines. In fact, 33% reported regular use of methamphetamines. 10% reported on non-prescribed opioids, but almost all of them, 90%, were also using methamphetamines. And we have almost no cocaine left in our drug system. Only 3% reported regular use of cocaine. 42% began using illicit drugs only after they became homeless. And before they became homeless, and 23% of everyone began using drugs regularly after they became homeless. This was one of our participants. I started, I guess you could say, using when I became homeless, meth. I would use it to stay awake at night. So it's not like I would need a fix in the daytime or anything else. Unfortunately, if I had to come up with the perfect drug to survive unsheltered homelessness, I would probably come up with meth. It's cheap, it keeps you awake and alert, it gives you energy, and it makes you not feel hunger. 9% reported current heavy episodic alcohol use, and about 40% either alcohol or substance use. Now, of those who reported these problems, so these are the folks who I would probably want to get into some form of drug treatment, only 10% were receiving any treatment, and it was almost all the level of treatment that we have the lowest quality evidence for, things like peer support. But 21% told us that they wanted and were seeking treatment, but had been unable to find it. And 26% told us at some point in this episode they have. In California, we are having unending conversations about forced substance use treatment. And I can tell you, as a physician who does a lot of addiction treatment, it works much better if people want it. We are having all these conversations about forcing people, but we're leaving the obvious completely open. We have all these people who are looking for it, who can't get it. 48% had what we call the complex behavioral need: current illicit drug use, heavy episodic alcohol use, hallucinations, or recent psych hospitalizations. Again, this isn't 48% of everyone who becomes homeless, but it's a snapshot look, and that means these are the folks who are going to need significant supports to become housed. Now, this is, I thought, pretty good news. 83% knew that they had some form of health insurance. It was almost all our Medicaid system, and about 95% when we did this study were actually eligible for Medicaid. 52% could name a clinic that they went to that wasn't the emergency department. 12% it was a mobile clinic like street medicine. That's sort of the good news. However, 39% had had no healthcare visits outside of the emergency department in the prior need. A quarter, 24%, an unmet healthcare need, and 23% an unmet need for medications. Why couldn't they obtain health care? Well, they had no transportation. They had limited access to phone or the internet. They would show up and they wouldn't have showered in days, and they would have their belongings with them, and they would feel unsafe. They had difficulty managing appointments, and they had a huge fear that if they went to the doctors, someone would come, usually the government, and take all of their stuff from their encampment. In the past 6 months, a whopping 39% had visited the emergency department. And perhaps even more striking, 22% had been admitted to the hospital for an inpatient physical health hospitalization in 6 months. It is hard to get admitted to the hospital. We try to treat everything as an outpatient, but more than 1 in 5 had. The high rates of ED use and inpatient use, high burden of illness, limited access to preventive and outpatient care. Some were then discharged from the hospital to unsheltered settings, and only very few were able to access things like recuperative care programs. Now, the experience was truly harrowing. 36% of everyone had experienced a physical assault during this episode. 10% of everyone had been sexually assaulted during this episode of homelessness. Among cisgender women, 16% had. Our trans numbers were small, but it was even higher than that. But one of the things that was really interesting was half was perpetrated by a total stranger. We know through violence studies that most violence is perpetrated by people in people's social circle. But once you become homeless, once you no longer have a door that locks, you were actually preyed upon by people who were not only in their direct social circle, but not even people they recognized or who were acquaintances. This is one of our participants. And I pray every day that homelessness, comes to an end, because I'm tired, you know. Not only do you have to deal with break-ins regularly, you have to deal with a male who might want to physically violate you, violently at that. There's robberies galore. There's always breaking and entering. Now, what kept people from being housed? I'll tell you one thing that didn't keep people from being housed. It was not that they didn't want to be housed. As one of our participants said so beautifully, if I had housing, I would go to an outpatient drug treatment program. I'd be working. I'd probably get a primary doctor and get my health in order. I would probably join a club or two, something fun. Housing, would change everything. But when we asked this question, our participants looked at us a little bit like we had three heads. In fact, I sent the team out, and the first day my cell phone is like going off, and my team is like, I feel really dumb asking this question, because people are like, what do you think is keeping us from being housed? Housing is too expensive. In fact, 90% said that it was the cost of housing that was a major barrier to their regaining housing. We talk a lot about like people getting all this help in California. People were not getting help. Fewer than half had received any assistance from anyone other than a family or friend to re-enter housing during this whole episode. And a quarter, 26%, had received any help at least once a month, which is not a lot, in the prior 6 months. People were just not getting any help. As someone said, there's just not enough resources out there for people who want to get out of being unhoused. You kind of just seem like you're stuck there. Even if you're trying to get a job, like you have to have an address first, and if you don't have an address, you can't get a job, and if you can't get a job, you can't stop being unhoused. So what do we do about this? Well, first of all, the primary response to homelessness, every single route to ending this crisis, is to increase the availability and affordability of housing. There is actually no other way we're going to end this crisis than to chip away at that disconnect between low-income people's income and the amount of housing. That said, there is a critical role for healthcare in this response, particularly in the alignment between healthcare, homelessness, and housing systems at all stages of the homelessness response system, from prevention to post-homelessness. So I like to think about it in three buckets. What do we do to prevent people from becoming homeless? We can't just leave people out there to die. So what do we do to mitigate the crisis of homelessness? And how do we improve and speed exits out of homelessness? So thinking about the healthcare and public health responses to homelessness, when I think about prevention is hard. People are now talking about prevention, and prevention is really important. The reason that it's hard isn't so much that we don't know what to do, it's that it's remarkably difficult to predict who's going to become homeless. Because a lot of people look like they're going to, and people are incredibly resilient, and actually not that many become homeless. But here's the exception to that, and that is people leaving institutional settings. If we have someone in our prison system, if we have someone who's been in jail for 3 months, and they have nowhere to go when they're leaving, I promise you they're going to become homeless. And if you prevent their becoming homeless, you have a 1-to-1 ratio. That's very different than in other homelessness prevention. Likewise, if we send people who've been in prison for 20 years to 3-month transitional housing, and then we kick them out to the street, that is not enough to get a job, to get training, to overcome all of the issues. So that would be my first priority. But there is more and more work done in how we actually identify people at high risk and move quickly with effective interventions. In states like California, we now have permission to use some Medicaid dollars to do so. I can actually write someone a prescription for 6 months of housing. I can pay for a housing navigator or first and last month's rent. That's really exciting. There's some excitement, and this kind of creeps some people out, but using big data. So my colleagues in Los Angeles have combined a bunch of data sources, are literally predicting based on things like if you have a domestic violence call to your house, if you sign up for unemployment, who's likely to become homeless, and they're literally calling people up. Now, when they first called people up, everyone thought it was a scam, so they hired a bunch of people who themselves have been homeless, and they're actually reaching a lot of people. I have this idea that our safety net healthcare systems are a really good place to do this. We know, for instance, that pregnancy is an incredibly high-risk period. People deliver babies in the hospital. We should be doing a lot better job of screening people. And we know that the one system that people have actually accessed before they become homeless is the safety net healthcare system. How about mitigating? We need a lot more low barrier shelters open that don't demand sobriety, that allow people to come with their children, that really create a space for people. And we particularly need non-congregate settings, not these 600 people, buildings, because lots of people are understandably afraid to do that. We need more street outreach, both with case management and housing navigation and with health services. There are alternative ways to treat people rather than send everyone to the ER, where they tend to get re-traumatized and not get the help they need. There are things like sobering centers where people with public intoxication can go, be safely monitored, engaged in the services that they need, or respite or recuperative care centers for people leaving the hospital rather than going to the street. We need more non-police crisis response system. We should not ask our law enforcement officers to suddenly become mental health providers for a lot of reasons. That's a really bad idea. And we've got to start with the low-hanging fruit. Arresting people for bringing homeless just creates a cycle and moves people from one place to the other. How do we improve exits? We first, I think, need to start with sort of the low-hanging fruit. There are a lot of people out there who don't need years of case management and long-standing income support. There are people who just need that first and last month's rent and a little house navigating the system. Those people are really deprioritized by our current system, and I think we need to reprioritize them and say, if we spent $10,000 on this person, could we get them out of homelessness instead of them figuring out after 9 months, get them out after 1 day? We know that some people are going to need short terms, 18 months of rent support while they're completing their nursing degree or whatever, and then can leave. And a lot of people are going to need a long-term housing subsidy. As long as we have a housing system that's completely disconnected from what people are actually paid, people are going to need a rental subsidy. Now, how about those folks with significant mental and behavioral health and substance use problems? They should be housed, and more importantly, they can be housed. We have now several decades of evidence of how to do this. It's about offering people a long-term subsidy with wraparound services that are offered without a precondition of sobriety or without needing to engage in treatment. This is not because we don't believe in treatment. I like to say I would have had a lot more fun in my 20s where I spent all of my time learning how to be a physician if I didn't think people needed treatment. I'm a physician. I think treatment is a good thing. I can also tell you, as someone who does a lot of addiction care, I got nothing when people are out on the street. The idea behind housing first isn't that it's housing only. It is that housing is at the root of safety and security. And once we get them housed, we can wrap around those other services. This has become incredibly controversial. It was really brought into a federal perspective by George W. Bush, who many people now claim was a San Francisco Marxist. You can say a lot of things about George W. Bush, but that he wasn't. But he recognized that getting 87% of people successfully housed versus 5%, he's like, 87% higher than 5%. Let's do it this way. It is now has a disinformation campaign and is being attacked on every front. And finally, the most severely behaviorally challenged people, you can get about 87% of them housed successfully. Some people are going to need more. They're going to need things like assisted living facilities for these older folks or residential care facilities for people whose disabilities are too big. And that's okay. We just need to make sure it's there. I like to say different individuals require different solutions. People require different solutions at different parts of their journey. Homelessness is preventable if we reach the right people at the right time with the right interventions. While people are experiencing homelessness, we need a response that matches their needs. And homelessness is solvable. Everyone needs housing they can afford. Some people will self-resolve their homelessness. Some need navigation, flexible funds to help them access housing. Some need that plus short-term subsidies. Others need navigation plus long-term subsidies. Some people need that, housing plus light touch services and supports. Some need housing plus significant services and support. And some are going to require structured, supportive long-term living environments. This is not rocket science. Homelessness is solvable. And as a physician, I like to say there is no medicine as powerful as housing. There is no other single thing that I can do that makes such a dramatic improvement in people's housing. I'm going to stop here. This is my contact info, and thank you. Do we have time for Q&A? We do? Okay, great. You have a question? Happy to answer it. Yeah. Any questions? I see one back here. Wonderful question. So asking about the Home Key grants. In California during the pandemic, we did something called Project Room Key, where we used empty hotels to bring people out of the streets. And then the governor's office turned it into something called Project Home Key, where local governments were given money to house people with the condition that they do it really quickly. It basically said, if you can get something ready to use in the next 6 months and bring people indoors, you can get a grant. So the answer is it's been remarkably successful. A lot of counties found things like hotels, that they just bought the hotel, threw IKEA kitchens in, and brought people indoors. So the good news is it's been remarkably successful. The bad news is they didn't really have a way to pay for like rent over the long term. And if you've ever lived in your house, you know that like roofs fall down, like houses cost money, and the people's income is so low that they sort of took the money and spreading it out for 5 or 10 years, but we don't really know what's going to happen if there aren't long-term rental subsidies after that. But so far in California, they've housed 10 or 15,000 people really, really quickly by asking people to be really creative. We've had some colleges that closed. People bought dorms and put little kitchens in them, bought motels that were no longer in use, did all sorts of things to get people in really quickly. So as proof of concept, it's been great. I think we're all waiting to see what happens over the long term. Yes? Yeah. Yes. 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 Great. So the question is variations from like rural to urban to suburban. So in California, we have it all. And I didn't show you how we did it, but we basically were in all of those regions of California. And there are definitely big differences. In our urban areas, you see these like huge encampments like Skid Row in LA and other sort of large, really just urban areas, or a lot of people living in their vehicles on city streets. In rural areas, it was super interesting. It really depends. We work with the United Farm Workers to identify, for instance, farm workers who were sleeping in fields or in their cars, and that was a pretty different phenomenon than other rural areas. What we found in most rural areas is most people, about 90% of the homeless population in rural areas, had migrated into the center city. So these were often tiny cities, 10,000 people, but it was where they had like a food bank and, food things. So most people in the rural counties were actually coalesced into these small areas. They were actually often university towns and the like, where there was like more central because people don't want to starve to death. But we did find people like hidden in the mountains and things. What we heard in the rural areas was it was like transportation. Housing was cheaper, but still not affordable. But people had no way to get to their jobs or to benefits or to food. In suburban area, a lot of people in suburban areas will also migrate to the nearest city. But in suburban areas, you saw more of like the extended stay hotels, more people living in garages, in family members' back door yards and the like. Yes. Here and there, if we have time. Yes. How those estimates are obtained of the 187,000, let's say? Yeah. Great question. So we think the point-in-time counts are not terribly reliable, but the one thing I will say about it is that they try to use the same method year over year. So I think it's best as like a snapshot. What they tend to do is that each continuum of care, so like LA County has 5, and in more rural counties, there'll be 2 or 3 rural counties with 1. They literally send people out on one night to count. It's like a census of people. They don't do a lot of fancy sampling methodology. I can tell you where we're heading in California, which is that all of our COCs, Continuum of Cares, report everybody. You have it to HMIS, where people have to, if you provide services that use any federal dollars, you have to enter them in the system. In California, all of that has been coordinated up to the state level. My team is currently working with the state to match that to other state records. Things like hospital discharge records, social service records, Medicaid records. What we're finding is that even those, which is, obviously gives you a better sort of annual prevalence as opposed to point prevalence, but also even in HMIS, we're missing probably between 1/4 and 1/2 of people who other systems are showing as homeless. And the hope is that we're going to use all of these to do, pardon me, I know it has a new name other than capture to recapture, but there's a method that comes from population ecology where you use like multiple systems that all have different forms of inaccuracies, and you can put them together to get a much better estimate. So I think that is where we're going to be headed in the future. I can tell you it's also a little politically sensitive, because like HMIS, or what we call HDIS, all the state records, because it's not a point prevalence but an annual prevalence, is about 4 times higher than the point-in-time counts, which makes electeds nervous, but it's because people are homeless for a short time. Many are homeless for a short time. We actually think that even those are vast underestimates, and that we can improve the estimate by combining homelessness reports in other systems. That is hard for electeds to hear, that the number is actually even worse than you think it is. But I think that is where we are heading as a field, to try to use, people showing up in other records as homeless and merge them and look and try to come up with better population estimates. It's a lower bound of a point estimate. It's the lower bound. Yeah. Great. Yes. 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 Yeah. Yes. Great question. So since racism is the elephant in the room, as we think of ending it, in what way do we tackle racism? So the first thing is we talk about it, and that we do, and obviously this has become harder in the current environment. We talk about it, and we undermine it, right? We now have fair housing laws, but we don't enforce them, and doing things like enforcing fair housing laws would actually go somewhat far, thinking about ways to repair the harm that has been done by disenfranchising populations. But I'm going to tell you some other more concrete ways. Because homeless systems have such limited resources, and we're basically triaging, what has been our strategy for many years now is to use people's priority score to get them into housing. And each COC gets to do their own priority score, but most Most places do it by things like the level of mental health problems, the level of substance use problems. Here's the problem, is that those scores unintentionally disproportionately help white folks, because white folks have so much more sort of structural protection against homelessness that white folks who experience homelessness are much more likely to have significant individual vulnerabilities. Now, Black folks who have those vulnerabilities are at really, really high risk, but many Black folks don't have those vulnerabilities and are homeless because their families don't have the wealth to protect them when they go through, a job loss, are homeless because they've had criminal legal interactions that frankly wouldn't have happened if they were a white person, because their families themselves aren't homeowners. If you are a homeowner, you can invite anyone you want to in your house. If you are a renter and you're in a skyrocketing rental market and your landlord kind of wants to get you out, having a person who's not on the lease live there is a rent violation. And so by doing this, and I don't think, like a lot of the ways racism acts, I don't think this was intentional, but by putting such an emphasis on individual vulnerabilities, you wind up helping a much bigger proportion of white folks than Black folks, because all of the excess risks for homelessness in the Black community are people who don't have individual vulnerabilities, but their risk has actually been their exposure to racism. So some places are trying to reverse that. So some of the things that places are trying to do is, and there's this weird way that fair housing laws are sort of weaponized. You actually can't use race as a reason to get more resources. But what you can do, for instance, is talk about census tract, because we know in our country we still are so segregated that you can use being last housed in an at-risk census tract, which means you're more likely to be a person of color. And truthfully, that is a good marker of having less network wealth, right? If you're from there, you're less likely to have a cousin who can lend you the $5,000. And so you have some places using a priority score if you lost your housing in a highly impacted census tract. Our prevention efforts, we're trying to focus them in these highly impacted census tracts. Again, it's because it's basically a marker for having less network wealth, and we know having wealth in your network can actually help you prevent homelessness or get out of it faster. We're trying to use things like history of criminal legal system involvement, because that is disproportionate and it is a way to help reverse that. But you need to be thoughtful about it. It made sense in some ways to use these individual vulnerabilities, but when you actually look at the data, it may be harming the equity of our responses. One more question. Yes. 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 Yeah. Yes. 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 Yeah. Yeah. Fantastic question. So, like, what kind of messaging do you use in more conservative requirements who maybe aren't going to be as motivated by equity or just of like the moral harm of homelessness? So I think there are two messages. One is like healthy communities are communities where everyone has housing. It serves nobody's interest to have people living in our parks. It makes the parks harder to use. It makes, it sort of doesn't increase community safety. And so one message is that healthy communities are communities where people are housed. There are two then different sort of business conversations about it. One is that homelessness is extraordinarily expensive. I have lost a little faith in this messaging because you know what else is extraordinarily expensive is the criminal legal system is extraordinarily expensive, and that hasn't really convinced people not to use that. But I think that insofar as you can say, look, whether you've got people in prison or you've got people cycling through hospitals, standing up like emergency responses. At the end of the day, if we could get people out of homelessness faster, that would be cheaper. And then the third thing is just a workforce issue. In California, in the Bay Area, the housing wage is $60 an hour. That's what it costs to sort of keep a family. It's like the wage you need for a 1 to 2 bedroom modest apartment within viable commuting distance. So sometimes I'll talk to business folks who are like complaining that they can't find workers. And I'll say, I hear you. Like you need your toilets cleaned and you need someone to serve in your cafeteria. Are you willing to pay them $60 an hour? And they were like, well, no, I would go out of business. And I'm like, exactly. I don't think you should, and I'll say, I agreed. I think you should give them a living wage, but I think we can all agree $60 an hour, that's a lot of money. We're talking about $15 an hour minimum wage in California, which we have to fight really hard for. And I sort of ally with them. And I say, I hear you. $60 an hour is a lot to pay, a housekeeper. I hear why you don't want to do that. But I'm also hearing you say you can't find any housekeepers. Well, someone can't commute 4 hours in each direction. They would spend all their time and all their money commuting. So how are we going to solve this? One thing that would really help you keep the workers that you need. Like AI is not going to do our housekeeping, right? And so I'm like, look, I don't think you want to do the housekeeping. And this is a way to keep a healthy workforce without you needing to pay the housing wage. And that has been a little bit successful. I think where I lose heart is obviously criminalization is incredibly expensive and people seem very happy to do that. And there's other economies around the criminal legal system and things. But I do think the businessy messaging and the messaging of like, look, you want to send your kid to the public school. If half of their classmates are living in a shelter, that's going to make the teacher's job really hard. Like trying to like put it in their self-interest has been a little bit more helpful. Yeah, thank you so much.
Thank you, Dr. Kushel, for an incredible presentation. Let's give her one more round of applause. Next, I want to invite my colleague Shannon Self-Brown up. Shannon, with April Ballard, directs the GSU's, the School of Public Health Center on Health and Homelessness, and we are going to have a panel next.
All right, good afternoon, everyone. Thank you so much for being here today. We are really excited to have this panel discussion and follow Dr. Kushel's incredible presentation. What I'd like to do is tell you a little bit about our Center on Health and Homelessness and share a project that we have recently completed with our community academic partners who are here today. And we will give a few results from the project that we have conducted together, and then I will invite everyone on the panel to the stage for a few questions and discussion. So just to introduce you to our Center on Health and Homelessness, we are a newly established center. We were established in October of 2024, and we are here in the School of Public Health at GSU, and our intentions are to bring faculty, staff, students, and community partners together to address homelessness as a public health issue. This is our CHH team. I see them sprinkled around the room. If you'll just wave if you're part of our CHH team. We have a small but mighty team. We've been able to do incredible work together, and so lucky to have all these staff and students that help make our center shine. In our center, we are focused on program evaluation, technical assistance, and research, and really supporting community partners in these efforts. We are working in a variety of ways on several projects in each of these areas, and we are currently creating a program evaluation module that we will be releasing this summer to our community partners to help in building logic models, the inputs and outputs needed to achieve measurable outcomes. We will be offering technical assistance related to these program evaluation efforts. And we are available to partner in research, everything from helping design research methods to answer questions relevant to homelessness and health, to bringing together teams of students and training them to do data collection, and of course summarizing the findings and creating reports that can really make impact and inform policy in the areas of homelessness and health. And we are, I'm sorry, these were actually slides from an earlier meeting. So let me just go ahead and spend some time introducing Joy Monroe and Sue Sullivan, who are incredible leaders in our community academic partnership. They have been working in hotels for the last 5 years in our community and around the Southeast, and we are so lucky to have them here today. April and I and our team at the Center on Health and Homelessness would have not been able to engage in this work in our community without these partners. It was really their leadership, their hard work, recognizing the challenges of individuals and families living in hotels that allowed us to establish this partnership. They secured funding from DeKalb County to count and enumerate the individuals and families living in extended stay hotels. And the reason this problem was very important to focus on is because, as Dr. Kushel was mentioning earlier about the points in time count, individuals living in hotels are not counted as part of the individuals experiencing homelessness in a community, which means that they also cannot benefit from service funding and efforts that are given back to counties to help support initiatives for individuals experiencing homelessness. So in this project, we work together to count the numbers of individuals who are living in hotels in our community, as well as for families with young children, ages 0 to 17, living in hotels. We were able to conduct a survey to learn more about what were the circumstances that allowed them to end up in the circumstances where they were living in a hotel, and what were the barriers that impacted them being able to move into permanent housing. We put together a team of community volunteers and faculty staff and student volunteers from Georgia State, over 50 volunteers. We went out every Saturday and Sunday for several weekends in the fall semester, and we knocked on doors at almost 50 hotels around DeKalb County. That we knocked on more than 3,500 doors together. And in this work, we were able to estimate that there are 4,664 individuals living in hotels in DeKalb County. And of this number of individuals that we counted, 35% of that sample is children. So nearly 1,700 children are living in these circumstances. Just to share a few of our most important findings from the extended stay count, in addition to enumerating, we conducted the surveys, and the surveys allowed us to see what were the risk factors that were making families most vulnerable. A few were economic in nature and very consistent with the data that were presented earlier. We saw that evictions, loss of employment, and raising rent cost are the things that make families vulnerable. They need a roof over their head for a night. They need their children to be safe and have a bed to sleep in, but they have had these risk factors that have left them vulnerable, and so they pay for a night of hotel to protect them for that evening. What then happens is that the hotels are incredibly expensive, and families get stuck in a really challenging cycle. Families are paying between $1,700 and $2,600 per month to stay in hotels, and that range depends on whether it's a single room or a double room, and whether families are paying daily or weekly on those rates. Interestingly, those rates, paying that amount each month, would allow them to actually live in housing. They could potentially afford rent in DeKalb County, because we know that rental properties range $1,500 to $2,300. However, if they're supposed to be paying about 30% of their living wage for housing, you can see where that discrepancy lies. And also, these individuals, the caregivers and parents that we surveyed, they are mostly working individuals. Many of them are working multiple jobs, and they're using about 77% of their monthly income just to stay in the hotel. So that leaves no money to save and no money to really do the things that you might need to do to get into permanent housing, pay a deposit, and a lot of times the deposits can be more expensive because of eviction records and poor credit. So these were the main findings and takeaways that we had, that families are really getting into these circumstances because housing is unaffordable, and then they're stuck in a really difficult cycle. We want to recognize everyone who is in this room. We had more than 50 volunteers, as I said earlier, who volunteered to help us do these counts and do these surveys. So if you're in the room today and you went out and helped us with this project, please stand. Thank you so much. We could not have done this project without you. So we will go ahead and invite up our community partners and April to the stage for a panel discussion. Thank you so much. All right, welcome to the stage. Good afternoon, everyone. It's so fun to be together again. We spent many, many weekends together. I will always know Sue is the very brave van driver, because she would drive us in the van around the community, all around DeKalb County with our volunteers for the day. And then Joy was following us with all the things that she had to set up, the pizza and the diapers and the different things that she knew were really incredibly important to helping the community, our friends and neighbors that we were trying to learn more about, answer the door and be willing to potentially complete our survey. So I will just ask if each of you would take a few minutes to introduce yourself and talk about how you came to the work of working with individuals living in hotels or experiencing housing insecurity.
Hotels have little kitchenettes. Otherwise, these hotels are just a small, think of the worst hotel that you've ever been in, and you've got a little box refrigerator and a microwave oven. Anyway, so I've been going now to these hotels for 7 years. I started, it was just based around knowing children are going hungry during the summers when they're not in school and not getting meals in schools. And so it was a volunteer group, and we made sandwiches, identified one hotel. And it was the first time I'd ever been out at a hotel. And I say I couldn't walk away. I got to know these families and the children and heard their stories. And so I continued. I found other hotels. And I just continued to say, I would hear the stories from these families, and I realized they had no voice. And so I said, well, I'm going to be your voice until you have a voice. So I just became this advocate. And so that's what got me into it. I'm still in it.
Thank you, Sue. Joy, what about you?
Hi. Okay. So what got me into it is I have a nonprofit. So I've often worked with families. When COVID hit, we shifted our focus from direct service to homeless prevention. So we had funds to prevent families from becoming street homeless, to keep them in the home where they were living. And so we would get calls all the time, and we would, of course, say, of course, we'll help you. We'll help you. Send us a copy of your lease and your identification and fill out this application, and we can help you. And when families from hotels called, and we would say, of course, send us a copy of your lease. Well, they didn't have it. So this was a population that consistently gets left out whenever resources are available. So even though I had over $1 million in homeless prevention funds, I couldn't help any families that were in hotels. So my funding partner at the time was United Way, and they were working on a program called Motel to Home. And so I got engaged in that because I wanted to see, well, if we can't help them with homeless prevention, what can we do? And so Motel to Home is a program that pays funds towards your security deposit and your first month's rent so that you can move out of a motel into an apartment of your own. And so when we first got involved in that program, we honestly felt like superheroes. We were just racing into motels. Do you want to move out? Can you get qualified? We can pay for your move-in. And so we were just moving families left and right and right and left. And then like the next year, prices went up, but incomes didn't go up. So it became more difficult. And so we couldn't help quite as many families. And so we spent more time doing outreach. And the more outreach that we did, the more I started to see not just the great work we were doing with Motel to Home and how many families we could move, but how many families we couldn't move. And so what were we going to do with these families? And how many were they? And why are families living in hotels? And I had all of these questions, and I couldn't seem to find the answers. And so I assumed it was because I'm not a researcher. So I assumed that was the reason. But then when I talked to the researchers, they didn't know. And so in the extended stay community, we all quote the Southern Poverty Law Center, who at the time said there were approximately 25,000. I think that number has gone now to 30,000 living in extended stay hotels, but that's the only statistic we were ever able to find. So I went back to my funding partner and I was like, we need more information. Somebody should really do something about this. And they were like, yeah, somebody should. And so the first study was in Charlotte, and I selected Charlotte because I have a lot of extended family in Charlotte, and everybody in my family has to do something for Spark at some time or other. So I went to Charlotte. Sue came with me, and so we did our first study in Charlotte, and it was about 7 hotels that we did there. And then from there, we went to Greensboro, because when we presented to the Charlotte United Way, the Greensboro United Way was there as well. So they said, we'll come to Greensboro and see what we have going here. After that, we came home and started doing unofficial surveys here. Sue led the work in DeKalb County just to make sure that we were able to get the first in the nation countywide study done. DeKalb was the first county that told us yes. And so that's how we got to do the study in DeKalb County.
Thank you so much, Joy. Would you like to share a little bit about your story and introduce yourself, April?
I always love hearing their stories because I think one of the things I feel like we have in common is just the commitment to really expressing and going around and telling people about things that don't often get talked about. And so that was really my gateway into homelessness research. I was working on the opioid crisis in Appalachian, Kentucky, and we were seeing tons of people who were reporting experiencing homelessness, but the point-in-time count numbers were saying that there were only 4 people in a county when we were having hundreds of people telling us that they were experiencing homelessness at some point. And so when I moved to Atlanta, that felt like an opportunity for me to be able to pursue that research on my own. And when COVID hit, my colleagues and I were really committed to being able to provide different types of resources for people because so many places were shut down. And so we were literally going around to the city, going to encampments, coming downtown, giving out hygiene kits, masks. We put on a vaccine clinic downtown because the city said that people would come to Mercedes-Benz to get vaccinated, even though we knew that they wouldn't do that. And so then coming to GSU, obviously, Sheena and I had the opportunity to start the center, and then Joy and Sue came knocking on our doors. And so it all worked out.
Thank you all. And so it's just so important that you've all been able in your career to focus on these hidden areas of homelessness. And I think it's in the hidden homelessness population where prevention really matters. And I think that was a really key part of the presentation. It is very difficult to think about the approaches to prevent homelessness, but these opportunities that you've all had in your career is really one approach that is incredibly important. So I'd like each of you to speak on why this extended stay hotel work is so important in the Atlanta area, specifically with the history of our city.
Well, I'll start. I think if most of you are from Atlanta, Atlanta, and maybe you don't know this, Atlanta has the second highest rate or the highest rate of evictions right now, highest rate of eviction. New York City, who has like 3 times the amount of housing, tenants, people in apartments, has less than us. So what's going on and why we have this crisis at hotels, and we have concentrated on families and children, but I want to say this is also a crisis for our elderly. There are a lot of single people in these hotels as well. But what happens and what has happened here in Atlanta is that Atlanta's a booming city, right? Everybody's coming to Atlanta. We have the Beltline. It's awesome. And rents have gone up. And all of our low-income Black and brown families who have lived here in Atlanta, the rent has gone up. It goes up $100. And these families are the ones who are working at Burger King and at McDonald's, and they're, the warehouse workers at Amazon. Rent goes up, and they can't afford it, and they get evicted. And once they're evicted, there's no place for them to go. And so they move into these hotels. They put everything in storage. They think this is a temporary place until they find another place. But, maybe they've been renting in a home for years, and then all of a sudden they've gotten this eviction, they go into a hotel, and now they start looking to find a place to live. And there is no place that they can afford because everybody's requiring that you have to make 3 times the rent. Now we're going to like 2.5 times the rent, but still. And they have this eviction on their record. So an eviction, it's the scarlet E. No landlord wants to take you, and it stays on the record for 7 years. And so that means now we have all of these families and children who are living in hotels for years on end, and it's devastating.
And one of the pieces of data from our report that you can see if you access our full report on our website is that the majority of the families that we surveyed, which was 231 families, had been living in the hotel environment for more than a year. So just to think about, someone thinks this is a very temporary fix. They're putting their things, in temporary storage, and thinking they'll do this for a week or so, and then here they are 3 years later in the same situation. So it really is challenging. Joy.
I think it's also important because this is the population that again gets missed in all of the categories. So even recently in Atlanta, our governor announced a $50 million funding stream for homelessness, but it's specifically directed towards street homelessness. So these families will be excluded from that. There was a Supreme Court decision a few years ago that said if you live in a hotel for a certain amount of time and that's your address and you can prove that that's your residence there, that you have a road towards being a tenant. Well, there's a bill in the House right now that's set to undermine that, so that these families will only ever be considered guests, never a tenant. So at the federal level, you're not homeless, but then at the state level, you're also not a tenant. So technically, you're not really anything. You just fall in this gap of nowhere land. According to the federal government, the children who live in extended stay hotels are homeless, but again, their parents are not. So children can receive services from the school through McKinney-Vento, but parents are ineligible for services. So the reason to focus on this population is because no one else is. And people are even actively working to ensure that they remain hidden, that they never are eligible for any services, anything that looks remotely like protection, such as the road to tenancy, to make sure that that's eroded, so that as fragile as their situation is, it will always be fragile.
Thank you, Joy. And in mentioning the McKinney-Vento Act, when we were surveying the parents of children that were school age, we did have a question in the survey about how many children that are living in hotels are accessing the McKinney-Vento services, and it was only about 25% of the sample survey that even really knew about the services and were accessing the services. And those services can allow for school continuity and academic support and transportation support. And so, DeKalb County, I think, thought they had a handle on the number of children living in hotels and ensuring that they were getting access to the services, but it was very much a significant underestimate. Anything to add, April?
I'll just kind of, I guess, maybe summarize what you all said. I think that Atlanta and the state of Georgia is kind of a recipe for the perfect storm. I think we don't have strong tenant rights, which allows people to be kicked out at the drop of a hat. So, for example, if you have mold in your apartment and your landlord won't fix it and you decide, okay, that I'm not going to pay rent, they can kick you out and file for eviction immediately, even if they won't fix the mold. Also, like Sue said, we have the highest eviction rate in the country in Metro Atlanta. We also, of course, are having a great population boom and some economic boom, but that's only for certain people. And so as the population rises, we have fewer houses. The price of rent increases, but we know that the minimum wage has not increased in the state of Georgia in a long time. So people who are making $15 an hour can't even afford the average rent to be rented to. And then on top of that, we have, I think, one of the highest rates of hotels, like extended stay hotels in the country in Metro Atlanta. And so it's almost like we have this, in quote, safety net that exists in our community because we know that this problem has been created. And people are just trying to do the best they can and get stuck in a situation.
And in addition to having the highest eviction rate in the country, we have the lowest economic mobility rate. So if you are born into poverty in Atlanta, you have less than a 5% chance of ever moving out of poverty in your lifetime. So all of the policies, all of the housing, all of the lack of tenant protections, all of the lack of protections for these families in general all contribute to, as you called it, the perfect storm. And so that makes Atlanta the epicenter of something like this.
Thank you so much all for your thoughts about why this is such an important issue, and especially here in Atlanta. Now, the next question is why we're here today. So we're going to really talk about this community academic partnership that we built to conduct this study. And we would just love to hear from the group if you can each share your thoughts on really what made the community academic partnership that we had on this project work well.
So I could start with this one. So I think that GSU has a culture of community and partnership and just a very welcoming spirit. I had done a presentation for a professor, and after that, I had been invited to work with his students and present to his students, and he had started working with me looking on some of the initial data. That led to me being invited to see if I wanted to host an applied practice experience in those students. And then that led me to meet another professor who also came on board and helped. Then we also received an invitation once the Center for Health and Homelessness opened up to come in and meet with the center. And the willingness to just partner with community agencies. When you run a nonprofit, you are very typically very busy doing the work. And you want partners. I wanted to make sure I had on. Our motto at Spark is single does not mean alone. So we want partners and welcome partners, but partnership sometimes just means more work. But what we had here with the Center for Health and Homelessness was an idea. It was a dream partnership. It's everything that you want in a partnership. It was resources, it was help, it was support, it was thought partners, it was boots on the ground, it was innovation, it was validation, it was, I mean, I could be here all day, so at some point.
It was friendships.
It was.
We were a team.
Yeah.
We were a team from like From day one, it was amazing.
Yeah.
I also want to say that I think was so important were all the student volunteers that we had. The students were engaged. They really wanted to understand the population. Like this, I remember years ago when I first started doing this work, I had a friend who had grown up in a community where she was poor, and so resources were brought in, and she said, I always felt like I was an animal in the zoo. People would come in to drop off food or whatever, and I just felt like they were all staring at us like we were animals in the zoo. Well, not one of, all of the students, everybody that was engaged, really opened themselves up to the vulnerability. And so there was never that feeling of, like, of who are you people, and treating people like objects. It was just this, it was amazing. It was just this openness. So thank you.
There was also a connection between all of the members of the team. If anybody had just been like casually observing us when we came today, the way that we all greeted each other, I have missed being with them on the weekends and missed having, the conversations and the meetings and the check-ins and knowing on Saturday and Sunday. And I'm not going to say that it was easy work. Some of this work was extremely heavy, but having strong, solid partners, the students, the faculty, all of the volunteers, it truly lightened the load and made something. I remember Sue and I sitting there thinking, like, we said we were going to do it before we thought about how we were going to do it. Yeah, we're like, yeah, sure we can do this. And then we were sitting there and we were like, wait a minute, how are we going to do this? And working with the center you truly were we said it before, you were the difference maker. You made this work truly possible. And then when the report was published, a lot of the way that it was received was because of the work that you guys put into it. So thank you again. Thank you all so much for that.
Thank you so much. And I think one thing for all of you who served as volunteers on the weekend, that Joy and Sue always opened up the morning by grounding everyone in why this was important. So really connecting to the public health issue that we were working through this data-based approach to make a difference on. And they also recognized that the work could be difficult and that many students maybe had not been in these kind of communities before, and they may see things that really might be challenging for them to carry throughout the weekend and make them feel very emotional. And so we always close the day with really opportunities to talk and share about the experiences that we had had. So that was an incredibly valuable teaching tool that you all use that I think our students will never forget. And you're so generous to say this couldn't have happened without us, but researchers don't get the kinds of opportunities to do this work unless you're going in with valued, trusted partners. And we would walk into the hotels and you would greet families by name. That's why they trusted us and allowed us to ask the questions that inform this data. And if you all had not done, all that work in the prior years, we couldn't have been as successful in launching the research. So thank you.
I'll just add that I think there were a lot of unique things about the partnership that made it work. I know we didn't get to present our slides, but we went to 42 hotels. That is a lot. And when we put the call out for people to volunteer, we were trying to get students to volunteer because faculty members know it's hard to get faculty members to do anything. And we had so many of you all in the audience and people who aren't here that are faculty members who came out and volunteered. We had postdocs, staff members, community members, Shannon's family. And I think that is so unique, and we hardly had any no-shows. And people volunteering, especially on the weekends, I think that there's just such a strong commitment to this work. And in that vein, I know we've talked about this a lot, that we were able to create a team of people who did not have egos in this. No one cared about their individual kind of praise for the work. It was about getting the data out there and making sure that this issue was heard by the community and by decision makers. And I think that really made a huge difference in this. And I'll just say, all three of us are Cancers. I know everyone was wondering, and I think that was really pivotal.
I'm a Scorpio. I fit in here.
For water signs. I think that was really important.
April and I even have the same birthday.
We do. Same year.
Well, I just want to thank all of you and ask the audience to join me in thanking Sue, Joy, April, and Shannon, and Dr. Kushel as well. This is really incredible. I think I really speak for everyone here in saying hearing the work and seeing the work that you all have done is just so inspiring. It really reminds us that the health of the community, as Dr. Kushel was saying, is a shared responsibility. And this is an example of where when we work across sectors and work together, we're more effective and we're really able to make a difference. And also center the voices of those with lived experience. So thank you so much. This concludes the 2026 Kreuter Katz Lecture. I want to thank you all for being here and for your dedication to improving health for all. Let me just ask that we end with one more round of applause for our panelists.